Do an intro for you. Good morning, everyone. Happy Tuesday that feels like mid-April, perhaps, in our weather. It's very nice. It's my pleasure today to introduce Dr. Miriam Kale. She's an assistant professor at the Duke University School of Nursing. Her research aims to improve health outcomes among people with childhood onset complex chronic conditions. And she's focused a lot on sickle cell disease, which is how Miriam and I met, because she co-leads the North Carolina Sickle Cell Data Collection Program, which is the 16-state program, one of which Michigan is funded by the CDC to conduct public health surveillance. She completed her Bachelor's of Science in Nursing at the American University of Beirut and her Master's in Pediatric Acute and Critical Care and Doctor of Philosophy in Nursing at Duke University School of Nursing. We have you're Tar Heel, right? Tar Heel sitting next to me in case you hear some grunts throughout this introduction. That's not me, I promise. So thank you for joining us. Miriam's been using this group-based trajectory methodology in some papers, and we've found it very useful and have applied it in other analyses too. And so we're looking forward to hearing more about how you've applied it, Miriam. You can go ahead and I see you're all set to go. So thanks everyone for joining.
Thank you so much for having me. It's such a pleasure to do this presentation. And I didn't realize it was mid-April in Michigan. I put this picture of our school in one of the snowstorms that we rarely get here in Durham, North Carolina, as a nod to Michigan and the snowstorms that happen in Michigan.
We're supposed to get like 3 to 5 inches on Thursday, so that will make probably a change, but that's all right.
So they say.
Yeah.
Well, enjoy the April weather while you can. So let me see if I can advance slides. Oh, Sam, we should have tested that. I'm sorry. Here we go. All right, so these are my disclosures, and I just want to point your attention to particularly to the last one. This presentation comes from a perspective of a clinician and health services researcher, not a biostatistician. I'm in no way and means an expert in group-based trajectory analysis. I have just used it in several papers, including my dissertation. So I did use SAS coding, and I kind of did the analysis myself with an oversight from a biostatistician. So I know a little bit more about it, but not an expert by all means. So just wanted to put that out there. And the scope of my presentation is from that perspective. How can we use it to really understand health outcomes over time? I'm sure this is not new for the researchers in the room and the biostatisticians. Health outcomes are not homogeneous, and this could be because of variable factors, not just biological, but also the physical environment, the social determinants of health that impact health outcomes over time. So the evolution is heterogeneous, and that means that within a certain population, we cannot assume that they will progress on a certain outcome, say, in the example of sickle cell disease, having higher acute care visits, for example, regardless of the characteristics of the patients, their disease etiology, their access to care, whether or not they have access to primary care. So all of these factors play a role and make the phenomenon over time variable and not homogeneous. So that sits it nicely to when we look over a certain outcome over time, and I've kind of think of it this way, when we're looking at the average and the mean of the population, we're missing that variability within the population. We are looking at variability for individuals relative to the mean, and not necessarily what is driving that change. So in contrast, it would be interesting to look at those trajectories on a certain outcome over time and try to identify how people behave, how they progress on that outcome over time? And are there different and distinct subgroups within that population that show a certain behavior on a certain outcome over time? That's the main premise of group-based trajectory analysis, is that basically within any group, there could be distinct subpopulations that behave differently or demonstrate outcomes differently over time. And that is interesting because, one, it helps us identify populations at risk for certain outcomes. It also might help us understand what is contributing to that trajectory and what is modifying that trajectory over time. So the purpose of group-based trajectory modeling is to basically identify those subgroups to predict the outcome over time, and then help inform interventions that might mitigate those risk factors that are contributing to the outcome. A major premise of this methodology is the trajectories are not pre-imposed on the data, they emerge from the data. And I'll kind of explain a little bit more about that when I show how we kind of model and pick the right model. It identifies the groups of individuals following that, as I mentioned, that similar progression on a certain outcome over time, and also can estimate the covariates or the factors that are affecting not only whether they are part of a group membership, but also the shape of their trajectory over time. And so the way I've used SAS, I understand there's a Stata as well package for group-based trajectory analysis, but I've used the SAS procedure with 95% confidence interval on trajectories. The first step is to determine the timeline. Are we talking about chronological time, or are we talking about age-related changes in that phenomenon? For example, if we're looking at emergency department visits over time and the mean emergency department visits over time, is it based on chronological time, meaning years, or are we talking about age-related? For example, ages 12 through 27, as I will show in one of the examples. So first, the timeline. And second, what is the outcome of interest and what type of variable it is? So for scale variables where is a ceiling and a floor effect, the C-norm model is the recommended model. For counts, the zero inflated Poisson model is the recommended one. And I've used both of these in my analyses. I have not used a binary variable, so I really cannot speak to the logit model. But basically, as you can see here, the statement is pretty straightforward. The website I've included on this slide includes a really good description of how to use ProcTraj if you're using SAS. And then there's a macro associated with that to help you set up the data, but also examples of how to apply the ProcTraj. So you call the data set, apply the confidence intervals right here. And then the variables are your outcomes of interest. The independent variable is the timeline by subject ID. And then you call in the model with the C-norm. Again, because of the floor and the ceiling effect, there needs to be a minimum and a maximum value. The order is the number of groups, which I'll explain in a minute. And then you plot the data. That's kind of like a very simple overview of what the coding looks like and how it is set up. Model selection occurs in two stages. In the first stage, we're trying to determine the number of groups that best describe the data. As I mentioned, the trajectory groups come or emerge from the data. They are not pre-imposed a priori on the data. And so the modeling takes place by running multiple iterations using multiple groups, anywhere from 2 groups to 6, 7 groups. I usually use my clinical judgments to think what I would expect of the data, and usually run about 2 to 5 or 6 groups. And then we compare the fit indices on that first model to determine the number of groups that best describe the data. And I've historically used BIC as recommended by Dagan, who is kind of the lead on this methodology, and select the model with the smallest BIC. So that's kind of like first stage is to run iterations of different numbers of groups to determine what number of groups best describe the data using BIC. In the second stage, this is where we start kind of playing around with the shapes of the trajectory and understanding how the trajectory changes shape over time. And so, you know, we would start playing with the shape by calling a quadratic or cubic or, you know, flat kind of trajectory. And then again, apply BIC to select the model that best fits the criteria. The model with the smallest BIC is the one that is selected. When two models show very close BIC, Jeffrey's scale of evidence can be used, which is the exponential between the two BICs, to determine which one has better support for the data. And then once a model is determined, a test of the fit of the model, of the selected model, is done by comparing the posterior probability for group membership. An acceptable limit for that is 0.7 for all groups. That determines the probability of misclassification between different groups based on the model that you selected in stage 2.
Miriam?
Yes.
On the chat, Kevin has a question. It disappeared, but I think it was, can you clarify what BIC is?
It's a fit indices measure. It estimates, I think, again, I'm not a biostatistician, so I cannot explain it very eloquently. It estimates the fit of the model, how fit kind of ensures that we're not overfitting the model with having more than what we should in terms of groups. Of course, the best fit model would be an individual trajectory for every single patient in the data set. And then when the grouping happens, if you end up with 3, for example, you've pulled those patients into those different categories or the different trajectory groups. And what the BIC does is it tests the fit of that model. Are we overfitting the model or not? And again, a smaller BIC is indicative of a better fit for that model. And I don't know if I answered your question.
No, that's great. Thank you.
Clearly. Any other questions about kind of how we select the model and what it's more of like an art and a science at the same time, and we keep running different iterations until we find statistically the model that makes sense in terms of BIC, in terms of posterior probability of group membership, in terms of entropy, but also does those groups clinically make sense and are they interpretable? So once the graphs come out, not only do we rely on those different fit indices, but also on the theoretical interpretability of the data, and does the data or does the trajectories in the graph make sense and can be interpretable from a clinical perspective. So it's kind of an art and a science at the same time. So I'm going to give a couple examples of how we've used group-based trajectory modeling to understand health outcomes in sickle cell disease, and one example in spina bifida. And just so that everybody is on the same page, a little bit about sickle cell disease. Sarah knows I will never miss a chance to explain this disorder. It's basically a genetically inherited blood disorder whereby genetic mutation to the hemoglobin gene results in polymerization of that hemoglobin chain. And instead of this nice and round and flexible red blood cell that you see on the left, you end up under certain circumstances such as stress, hypoxia, with sickling of that red blood cell. It's also more likely to hemolyze, it damages the blood vessels, and it has a shorter lifespan. So patients end up with anemia, they end up with hemolysis, and they end up with inflammation to their vessels. And as you can imagine, this can affect every single organ system in the body. So patients end up with strokes, they end up with retinopathy, shoulder pain, and avascular necrosis or death to the bone tissue, hepatomegaly. Every single organ system is affected. The hallmark of the disease is our sickle cell pain episodes, severe episodes of pain, whereby patients need to receive narcotic to release that pain and hydration. And the management is really complex. It's a combination of preventing organ damage, pain control, and improving health status in general. The issue with one issue with sickle cell disease is that premature death. On average, patients live to the 4th decade of life. This has improved drastically since the 70s, where we had a very high death in the pediatric age group due to advances in care, introduction of penicillin prophylaxis. We've improved the survival of pediatric patients, but we can still see that during that adolescent, young adult age group, around 19 years of age, there's a high peak in mortality in this age group. This is data that was from 2006. Unfortunately, updated data from Dr. Hassel in 2016 shows that those outcomes are still poor, and we still see increased death among people living with sickle cell disease beginning in late adolescence into early young adulthood. So this is kind of what informed my first study, looking at morbidity associated with that transition age group, ages 19 to 2026. And what I wanted to do is understand, how does disease severity change over time? What we know about disease severity anecdotally is that it increases with time, meaning that as patients get older, they get more and more sick. The question is, can we identify different, again, trajectories whereby patients show different behavior in terms of their disease severity over time? And then can we predict from early adolescence where that patient is going to land on what trajectory, and what factors might be contributing to their increased severity or not? So that was the purpose of this analysis. It was mostly for my dissertation, to look at longitudinally at clinical characteristics and disease severity for this adolescent young adult age group as they're transitioning from pediatric to adult care. Any questions? I'm sorry, did I hear someone? Okay. So we included patients with sickle cell disease. At the time, Duke had a deduced database where I could query and pull patient records from it and apply filters. So we wanted to include patients who had sickle cell disease initially based on ICD codes. Then they were seen in the pediatric clinic, meaning that they were followed up in the pediatric clinic during adolescence. So we applied those filters, extracted records on 553 patients. At the time, there was no sickle cell data collection program and confirmation of a sickle cell case. So what I did was a chart review of those 553 and looked for the genotype documentation in the chart to determine if they had sickle cell disease. And then we included patients who had at least 2 pediatric visits, so that they kind of were being followed up in peds. One had to be after age 15 because we wanted to make sure that they were in the transition age group. And we followed them up until age 27. And so we looked at their data from ages 12 to 27. and pulled a bunch of variables. I'm not going to go into details on this, but if you're interested, I'm happy to answer questions. Looking at sociodemographics, again, those variables that might influence that trajectory, and thinking holistically about what could impact disease severity and what could impact healthcare utilization for this patient group, because that was another health outcome that I was interested in, looking at their healthcare utilization. So we pulled data using ICD codes, zip codes, comorbidities. We looked at their prescriptions, outpatient medication reconciliation records, and then we calculated, I'll go more into detail how we calculated their severity over time. Then we looked at transfer factors because I was interested in their transition from pediatric to adult care, a bunch of variables there, and their utilization. So this was a huge study, again, a dissertation work, so I'm not going to present all of it. I'll focus on the group-based trajectory analysis piece of it, but I'm happy to answer any questions if you have about how we thought this through and what variables we used. So to calculate severity, we used a scale that was developed, I think, in the Netherlands at the time for a pediatric population. It was validated in one study. It was not extensively studied, but it was the only thing out there that quantitatively measured patients' disease severity. We did not have access to all of these data in the electronic health records, so we focused on the comorbidities or the complications, of sickle cell disease, whether or not they had necrosis, cerebral infarcts, some of the common complications. Some of them were present or not present, so a binary variable, and others were a certain number of events that occurred over a period of 2 years. We did not have access to lab data, so we dropped that from the analysis, and so we modified that score, and we calculated it from ages 14 to 27, again, because we needed 2 years of data for the acute chest syndrome and the painful crisis. But we calculated a score for every single patient in that data set based on whether or not those complications were reported on the medical record. And so we ended up, when we plotted that disease severity over time, so your x-axis is the age in years for the patients. So we transformed the chronological data to age-related data and calculated the score, the severity score for each patient based on their years. We included patients who we had data on for 10 years so that the model is stable. So that dropped our sample from 339, I think, to 113 patients, if I remember correctly. And the y-axis is their mean modified severity score. And looking at group means, you see an increase in disease severity over time, but you cannot tell who has worse severity and why. And so the question now becomes, were there subgroups of patients with different severity trajectories, and what were their characteristics? Can we predict who they are early on in PEDS? And so this is where group-based trajectory analysis came in handy. So we ran the models, again, two-stage selection process, and ended up with a five-group model. In retrospect, now, because of the small, so you can see the sample sizes there. In retrospect, I would have chosen a two-group model, one that has increasing severity and one that has stable severity. But what you can see here is there are 3 groups, the green, yellow, and red, that seem to have low, medium, and high severity, but that severity does not change much over time. And then there are 2 groups, the black and the blue, small numbers, but they seem to have increasing severity over time. And so, again, in retrospect, given the small sample size, I think I should have gone selected a 2-group model instead of 5. Clinically, it made sense at the time. And so to understand the differences between the 2 groups, because of the small sample size, we ended reclassifying them into stable severity group and increasing severity group. to kind of have adequate numbers in both. And then we did a univariate followed by a logistic regression model to identify the characteristics of those two groups. And so the patients in the increasing severity groups were older, they lived closer to clinic, they had higher odds of sickle cell complications such as acute kidney disease, which was an interesting finding. They had less pediatric clinic visits, but were more likely to transfer and remain in adult care, which could probably be because they had more severity, so they were having more frequent visits. But I think again, this was my first time using the model, still trying to learn it. And it helped us, one, actually document the increased severity over time, identify different subgroups of people that have different severity, and understand a little bit their characteristics associated with those trajectory groups.
I have a quick question.
Any questions? I'm sorry.
Okay.
Yeah, so I'm struck that you combined all the stable severity into one thing, because like in the box, you have higher odds for complications and comorbidities. I would think the green line probably doesn't, but I would think the red line probably does. And so what you have gained in looking at the stability, it seems to me like you've lost in terms of the heterogeneity of those groups, that the focus on the trend as opposed to the state of where they're at it's quite a trade-off.
I agree with you completely. Again, the limitation of this data or of these data is the small number in each of those groups. Had we probably had a higher number of patients, we would have had a more stable model and a better predictability of the disease progression. So huge limitation of this analysis was the small sample size. And we tried to, impose the 10 years data so that we have a stable trajectory, but the end it cut our sample by 2/3. So instead of 330, we ended up with 100, I think, and 13 patients whom we followed over this period of time. And that decreased the sample size. And this is one limitation of group-based trajectory analysis, is that sometimes it overestimates the number of groups. And again, in retrospect, probably we should have gone with a smaller number of groups that were more meaningful to interpret than 5 groups with stable versus unstable trajectory. So your point is very well taken, and I agree with you completely. Again, that was a good learning exercise for us to understand this method better.
Just another comment. All right, do you want to?
No, you go ahead, because I was, there's a question from Melinda in the chat. Is it okay that the two lower trajectories overlap?
That's another great question. Yes, it is okay, because again, patients might start at the same point in time on a certain outcome. They might start at the same level. The interesting piece is how they diverge, and that's part of understanding the development of the phenomenon that you're studying over time. Again, this is not the best model that we have done, but I think the reason I wanted to show you this is to kind of show you how sometimes group-based trajectory analysis is a great method to identify different groups, and how relying only on the fit indices might not be the best approach to understanding or to describing that phenomenon and its model interpretability and what it means and how it can translate to clinical implications will be important considerations in model selection.
Thanks, are you gonna comment?
I actually think it's good to have this, this is helpful to me to have stable, low, medium, high, to have this many groups, just because green is what we want, right? Everybody else is bad, right? Either they're stably bad or like they're getting worse, right? So in some ways, the green I feel like the green group is the most important group. Because it's almost like that, we want to find out why
That's the
they
goal.
are doing,
Right.
why are they doing so well? And everybody else is doing so terribly.
Again, my concern with this model is the small numbers. I would feel more confident and comfortable if we had a larger sample size where we end up with at least 30 to 50 patients per group, right? Or at least in most groups. Again, there might be, and in sickle cell disease, we might identify people that on a certain outcome, for example, emergency departments visits. This is one study we're looking at right now. 1% of patients contribute the majority of emergency department visits, looking at a statewide data set. The other limitation is we relied on ICD codes to identify those comorbidities and to calculate the scale. And we relied on ICD codes in one electronic health record data source. We did not have data from other hospitals where patients could have gone for more VOCs. So we might have undercounted their vaso-occlusive episodes. We might have undercounted their complications and their severity. So a lot of limitations, but again, I don't want you to kind of focus on the exact findings of this. It's more or less how this data could be, or how this method could be used to understand different trajectories over time. So small sample size, we did not capture all the data. All of those are limitations to this analysis, but
I think you're being too hard on yourself.
I'm sorry, I'm being hard on myself. No, I'm being realistic about, you know, the small sample size. It is a small sample size.
Jeremy has a.
Sorry, go ahead.
Yeah, no, it's like, I'm just curious with the small sample size, what these, what the dashed lines represent, the confidence intervals, because
The
with these.
confidence intervals, absolutely. And that tells me that we probably overfit that data.
All right, and then Kevin has his hand raised. Go ahead, Kevin.
So I have a general question, not specifically about this model, but what these trajectory models can do potentially for us, Miriam. So if we look at your lower two lines there, the green and the blue, with this diverging behavior, can these models help us understand, let's say, what went on at age 18 years that caused the divergence? In other words, let's just make up some stuff here where the green line is good, bad outcomes are low and stable, whereas at some point something happened and the blue line diverges with more bad outcomes. I want to know what's going on at age 18 that caused that. Can these models help us understand that?
Absolutely. So that's where the covariates that you include. So the way I've used this group-based trajectory method was to assign group membership to each patient in the data set, and then look at the characteristics. So group membership now becomes the outcome variable, right? If you're in the green group versus if you are in the, say, red group. And then you compare between those groups on those covariates. So let's say at age, I don't know, 18, we have data on, for example, patients left their house and ended up, I'm just making this up, all right? So they left their house and they ended up going to college, and now they're not taking their medications, and now they are not going to their doctor's appointments. We could look at those variables, whether or not they're contributing to whether the patient ends up being on the green trajectory or ends up being on the blue trajectory with increasing severity.
Okay, that's exactly, because imagine in the mirror image of this where like you do some intervention and bad stuff stops happening because more people are compliant and taking their meds, right?
Yes.
So
Does it interrupt the trajectory? That is possible. I've not done that sort of analysis. That is possible. It's also possible to use this method to also control for some variables that you want to examine across those.
Okay, so I have one sort of related question. I don't want to hijack the discussion, but something that I just want to put on the table is, can group membership be time dependent? In other words, can I hop from one group to another?
No,
So in other words, I become compliant and then I jump from one to the next, or do I have to stay in the same group?
the trajectory of your group would be different. So
Okay. It's like a crossover group or something.
So you will not, there's no way patient A will be in at age 14 in the green group and then at age 24 in the blue group.
Yep. Okay. Thanks.
They would stay in the blue group throughout.
Okay.
And that's what determines the blue group as the increasing versus the stable versus the decreasing versus,
Okay. Got it. Thank you.
of course. And I wanted to show you, you know, this was not completed in terms of we've not published this data, but we also looked at count data, so number of visits. So the previous analysis was a scale data that had a ceiling and a floor effect. Continuous count data could also be modeled using group-based trajectory analysis. And what we did in this analysis is look at the mean number of ED visits for each patient at each age group. Again, trying to understand how utilization changes as they transition from pediatric to adult care. And to your question, Kevin, the green group on the right side or on the left side is the same as the green group on the right side. So the patients could not jump between groups as they transition to adult care. And what this tells us is that if you start utilizing, if you're being if you're using pediatric healthcare a lot in peds, you're probably going to end up using adult care as well. So you can see some similarities between the two. There are less utilization in adult care, which we know anecdotally, but this shows the transition from pediatric adult care and how things are moving, how they're using the clinics. You could also model hospital visits, emergency department visits.
Mary,
And
can I ask you something?
Yes.
I think I got confused and now I'm catching up.
Yep.
Those lines represent the trajectories of the groups in the slide before. These are not new trajectories based on their utilization, correct?
These are new trajectory based on their utilization.
Okay.
And I'm sorry for not being clear. So
No, that's
in the previous slide, we calculated severity, which was a scale variable that went from 0 to 200. So a floor and a ceiling effect. Utilization is number of visits, basically, per year based on age. So at age 12 through 27, how many pediatric visits did they have? And then we modeled that. We did the group-based trajectory analysis and defined the number of groups, which ended up being 3. So there's a group that starts low in peds, which is the green group, and continues to be low in adult. Medium in peds, the blue group, and continues to be medium in adult. And high in peds, continues to be high in adult, although it's higher in peds. So what this is saying basically is, one, it looks like 17 to 18 is the age of transition for this patient population, because that's when you start seeing them picking up in adult care in terms of visits. And then 2, whatever their utilization is in pediatrics is going to be similar to their utilization in adults. So if they're utilizing if they're utilizing the clinic frequently in peds, they're likely to utilize the clinic frequently in adult, although to a lesser extent. Does that make sense?
Thank you. Yep, thanks.
I think it will make sense when we talk a little bit more about emergency department visits. So the same thing, we've identified 2 or 3 groups. That was a preliminary analysis. And so it looks like there's one group that does not utilize the ED at all. That's the green group. The blue group is a group that utilizes the ED maybe 1 to 2 times a year. But then there is this high utilization group number 3, which is in red, where you can see again at ages 17 to 18, that number of ED visits is really picking up quickly and peaking. And that's 18 to 20 visits a year. That's a lot of emergency department visits.
That's the end of that group was just 9 patients, is that correct?
I don't have the N off the top of my head, but it was a smaller number of patients, yes, and with our data now looking at the whole state, again, this was just one hospital at Duke. We are finding out like 1% of the patient population in our state contributes most of the ED visits of 20 and more. So yes, it's a smaller group, and then you can start seeing the confidence interval really widening towards the end because of the small N. But I can't remember off the top of my head how many N, but that's an important question.
Miriam, Melinda has a question in the chat also. In these
I'm
models.
sorry, I can't see the chat, and I really
No, that's
appreciate
fine.
you reading
No,
that. Thank
we
you.
always have that trouble, so that's why I'm the go-between here. In these models for the clinic visits, there were some patients who used the adult. Were there some patients who used the adult clinic while they were still under pediatric care? Is that what these models are showing?
No, some of the patients transitioned. On average, there was about, if I remember correctly, there was about 7 to 9 months between the last pediatric visit and the first adult visit. Adult sickle cell, again, being in the clinic. So no, what this is showing is not all the people had the visits at the same time in the same group, if that makes sense.
Great, thanks, Miriam.
For the sake of time, I think I'm gonna skip this. And then move into Melinda's study, which basically what Melinda and Sophia did is trying to understand the patterns of hydroxyurea adherence in people with sickle cell disease. We know hydroxyurea works as a disease-modifying therapy for sickle cell disease. The studies that have looked at this looked either at self-report or looked at adherence based on the number of prescriptions filled per year or the total days covered. The question again is, are there different groups within the sickle cell population of how they're filling their prescriptions and what factors are contributing to better adherence? And that was Melinda's question. And so, you know, but she used data from the California Sickle Cell Data Collection Program, about 713 patients who were on Medicaid or enrolled in Medicaid during the time. Both pediatric and adult patients had at least one hydroxyurea prescription filled between 2010 and 2017. And then she followed them for 1 year post their first prescription, filled to understand how they're filling their prescriptions over time. So we calculated a medication possession ratio for each of those patients for a period of 12 months. And then she modeled that using group-based trajectory analysis. And what you see here are 3 different groups identified. The red group that starts, the x-axis is the date. Again, this is not age-related here. It's a chronological timeline. 1 month post hydroxyurea prescription filled all the way to 12 months. And then the medication possession ratio mean on the y-axis. And the best fit model was a 3-group model where patients in the green group, for example, and that was 263 patients, so about the third of the patient population, had relatively high medication possession. So throughout the 12 months, each month, they filled their prescription about 60% of the time to 70% of the time. This is considered high adherence to medications. The orange group started at about 40%, but then it drops down to about 10%. And the red group started lower than the 3 at 15%, and it drops down to 0. I think what is important about this study is, 1, it shows that there might be a critical window at this 3 months to 4 months range, where you see a decrease in the prescription refill rates for hydroxyurea. It shows that there are patients who are more adherent than others. And so this is where she did a multinomial logistic regression to try to identify the differences between those groups and whether or not we could predict who can be in the membership in this high adherence group. And so she looked at a bunch of variables. The ones that came back significant in the model was age group. So pediatric patients were more likely to be in this high adherence group. And that's not surprising from a clinical perspective, because usually it's the parents that follow up on prescription fills. And so again, it tells us, you know, there's some disconnect with the young adult and adult population. And is there something where the interventions need to focus on that age group and need to focus on, once a prescription is given to a patient, that follow-up for probably the first 3 to 4 months might be important to ensure adherence or to improve adherence to hydroxyurea in this patient group. And let me pause here and see if there are questions. I do see something in the chat. I'm not sure if
It's nothing new.
I'm not sure if it's something new. I only see a red alert.
It's not a new question. You've got them all.
All right. Let me see. I do have one more study to go over for spina bifida and how we used. So the previous 2 studies that I've shared were retrospective analyses of either medical records or Medicaid claims for hydroxyurea. This example illustrates the use of data that was collected for another purpose, for an auto-1 that looked at health outcomes for babies, for children with spina bifida, looked at psychosocial factors, and it was a prospective 4-wave data collection that included family function. So we had a lot of variables that we could include in the analysis. Before I go to that, are there any questions about what I've presented so far before I go into this study? Okay. So just again, to get everybody on the same page, spina bifida is a neural tube defect, basically whereby a deformity during embryonic development, the neural tube fails to fuse correctly, and it ends up with either meningocele, which is herniation of the meninges around the spinal cord, and some spinal fluid kind of protruding from the back of the child, or you also have meningomyocele, whereby also nerves herniate through that sac. In either of those 2 situations, and depending on the level, it can be all the way from cervical, from the neck, all the way to the sacrum of the back. The higher the level of involvement, the more severe the disease is. If nerves are involved, that's a more severe form of the disease. But most patients with myelomeningocele end up with issues with bladder control, bowel control, and depending on the level of the lesion, with mobility. So they tend to be chronically on continuous intermittent cathing or clean intermittent cathing, whereby they would insert a Foley catheter to drain the urine outside of, so they cannot pee normally. They would need to insert a catheter to empty their bladder. So for this analysis, I worked with a urologist, and they were interested in understanding how do children with spina bifida, how do they learn to do intermittent cathing on their own? Because this is a childhood disease. Typically, parents do it when the child is young, and as they get older, we would like them to be more involved and take care of themselves. And so the question became, well, are there different trajectories or are different patterns whereby different patients end up learning at different times or taking full responsibility more than others? And what factors that play into that? And we use data from this prospective study by Dr. Holmbeck, who has been studying children with spina bifida for the last, I think, 10 years. He had 2 R01s and collected data on a bunch of variables, including clinical, psychosocial factors, family functions, as I mentioned. And so we structured that data or that analysis based on the data available through that data set. And our objective was, 1, to determine if there's different trajectories whereby children acquire more responsibility or catheterization, and then 2, what predicts more responsibility in those patients. So the same thing, this was a scale whereby we, the outcome of interest was a self-report scale that parents and children filled on who's doing the intermittent catheterization. And it ranged from 1 to 3, with 1 being completely dependent on the parent, 2 being shared, meaning the parents do it sometimes and the child does it other times, and 3, the child does it all the time. And so we mapped that out, or we plotted that over the child's age, and you can see there the age group. And the reason we have 8 and 9 years old, 10 and 11 years old is because we had smaller numbers. Again, learning from that first study that I did, we tried to increase the numbers to have at least 25 to 30 patients per age group to stabilize that trajectory. And what you can see here, looking at the means again, is that in general, the patients, as they got older, they took on and more responsibility. That started at about age 8 and 9, with almost shared responsibility for catheterization at age 2, and increased over time, almost reaching, you know, 2.6 to 2.7, which is pretty much good independence. And again, the question became, is everybody on the same trajectory, or are there different trajectories based on, for example, the type of lesion that the child has, the stress level in the family, as reported by some of the psychological measures that were collected during the study and the observational measures that were collected in the study, or did everybody follow the same trajectory? So we applied group-based trajectory analysis, and you can see the results on the right side of the screen, whereby we identified 2 groups. One that had lower scores on the scale, on the independence scale, and remained low throughout the teenage years. That was about the third of the sample, which is the green group, about 36% of the sample. Most of the patients, however, started with shared responsibility at age 8 and 9, and they slowly, over time, they increased that shared response. They slowly increased their independence in doing catheterization. The good thing about this analysis is, 1, this group 2, or group 1, actually, could be masked if we're only looking at the means, and we could have completely missed this group. The other thing that this analysis adds to the literature is that it identifies the time at which children can start doing independent catheterization, which is really young, 8 to 9 years. So it provides guidance to urologists and clinicians on when to start encouraging parents to have the child be involved in their care. Now, the question comes up, what's the difference between those groups, and can we try at least to understand why that green group remains low on that scale? And so we did a logistic regression, and we found out, not surprisingly, higher IQ, again, because spina bifida can affect IQ. Higher IQ was associated with higher odds of being in this increasing trajectory. For every increase of 10, about 10 units per IQ, the odds increased by 1.7. to be in this high independence group. Females were more likely to be in the high independence group. And the family stress scale is, the higher scores indicate higher stress. So the less stressed the family is, the more likely that the patient will end up being in the high independent catheterization group. So those are some of the variables that we found to be significant. Others were not. When put in the model, they were significant by themselves, but when put in the model, but it kind of starts to draw a picture of when is probably the right time to start teaching children with spina bifida to catheterize them, to start catheterizing themselves. And two, it clarifies the expectation that not every patient will be able to do it independently. And some patients, those that might have, for example, a higher lesion, that have lower scores on IQ, that have a stressful family dynamic, or female versus male, they might have higher odds of not being able to completely transition to independent catheterization. Any questions about that? Clarifications about what this data means, or the model, or how we chose it?
Just a quick question, if I'm understanding right. When you develop these models, you're basically using all the data of that time period for every patient. So this is a model describing the trajectory of patients. You're not predicting the trajectory, because you're using the past and more. You're using the whole spectrum of data to actually develop a model.
Yes, we use the patient's data to develop the model, but when we run the regressions, we're trying to identify some of the characteristics that, again, you know, predicting or not predicting, it's probably association because it's not prospective data collection. Yes.
Like what variables are associated with group
I'm trying to
membership?
understand the groups, not to predict any individual patient's behavior.
Correct.
Yeah, that makes sense.
But it helps inform the clinician, right, who's
Right.
taking care of those patients as to when should we start thinking about. I think those are the clinical implications that are important, is when can we start thinking about teaching children with spina bifida to self-cath, and then two, who has higher odds of being successful. And again, it's a clinical judgment, a clinical assessment. Each patient is different. Not everybody falls on those trajectory groups. And again, sample size, you see the confidence intervals around the green group is wide. So not sample size. I know, you know, you guys said don't be hard on yourself, but this is a small sample of 140 patients. So it's, again, not a lot of people. But the richness of the data is in the variables that were collected as part of the initial study that we used to kind of associate with those different trajectories.
Miriam, we're getting close to the end of time, and I just want to make one other comment. I think of the applicability of this too, is when you're thinking about prospective studies or other studies, even the preliminary data in this of, okay, these are the variables that we probably need to stratify for, or or our confounders or something. Like, I think that these analyses really, really inform additional, like not only clinically, but, you know, statistically and study design wise, we should be thinking about in the future.
Absolutely. Absolutely. And again, this is not the best modeling method for everything. There's I've included a couple of resources that describe some of the limitations of the models. And this paper is excellent at was way over my head. Again, not a biostatistician, but was very, very correctly critical of some of the limitations that this modeling technique. So it's not good for all data. It's good for some data. It's good for us, depending on the research questions, how the distribution of the data is. It might be helpful to understand at least some of those different patterns associated with that. And I'll send those slides to Sam so that she can share them with you, and you can have those resources. And I'm happy to take questions offline as well, based on the analyses that we have done.
Great. Thank you so much for joining us today, Miriam, and talking about group-based trajectory modeling. And
Thank you for
as
having
always,
me.
it was great to hear about your work. So thank you very much.
Thank you so much.